Good morning, everyone, and welcome to another program sponsored by TIRO Multidisciplinary Seminars. We are joined this morning by two experts in the field of salivary gland and lacrimal gland dysfunction associated with exposure to radioiodine therapy. I want to just bring to everyone's attention our podcast program titled Voices of Wisdom. We recently had another podcast that dropped as these will hit your inbox every month. These have been outstanding quality and encourage you to listen to them. This morning, Dr. Clemence Baudin is an epidemiologist who is a member of the French Nuclear Safety and Radiation Protection Authority. Dr. Baudin has a specific research interest in the health effects of exposure to ionizing radiation. And in today's discussion, she presents the interim analysis of a cohort of thyroid cancer patients treated with total thyroidectomy and 2 different doses of radioiodine. The current study provides a detailed analysis of salivary and lacrimal function at 6 months following treatment. My understanding is that there has been a repeat analysis and at a later point that is yet to be published, but we may ask her for a sneak preview of what that demonstrated. I am extremely pleased to introduce our discussant this morning, Dr. David Eisele, who is the Int'l professor and director of the Department of Otolaryngology, Head and Neck Surgery at Johns Hopkins University School of Medicine. He served as professor and chairman at the Department of Otolaryngology, Head and Neck Surgery, and was the director of Head and Neck Oncology program at UCSF until 2012, when he crossed the country and became member of the faculty and took over as chair at Johns Hopkins. Dr. Eisele has held numerous leadership positions at a regional and national level. His clinical interests include both benign and malignant tumors of the head and neck, and he has special interest in salivary tumors, salivary function, minimally invasive approaches to addressing problems with salivary gland dysfunction. And so he is really a perfect person to discuss this morning's presentation. So with that, I want to thank everyone for joining us. And as always, I encourage our listeners to send in their questions, which I will try to field by the end of before the end of the program.
So thank you very much for the invitation, and I'm very happy, and it's a pleasure for me to share my results on the START study. So this study was set up in 2020 by our team in collaboration with the University of Barcelona and the Hospital of Pitié-Salpêtrière, mainly Professor Charlotte Lucet. So I present a little bit myself quickly. So as you said just before, I'm a PhD in epidemiology at the French Authority for Nuclear Safety and Radiation Protection. And I'm working in the laboratory of epidemiology, and my research area are focused on medical workers. So I'm working on the ORICAMS cohort, which is a cohort who includes medical workers exposed to ionizing radiation. And this national cohort has been included in the BICOM project, which is an international cohort, a joint analysis with the French, Korean, and the US30 cohort. I'm also working on nuclear workers, and mainly on the contract workers in the co-worker study. So it's a French study, but I'm also included in the InWorks cohorts. I guess you already heard about that cohort who combine the French, the American, and the British cohorts. And I'm also working on the patients, so with the START cohort that I'm going to present you today. A little words on my institution. So I am working at the French Authority of Nuclear Safety and Radiation Protection. which is born the beginning of the year. It's the measure of the ASN, so previously the Authority of Nuclear Safety, and the IRSN that you already known maybe before, the Institute of Radiation Protection and Nuclear Safety. So now we are merged together and we are one institution, but we have many places in France, but the main places are near Paris, so in Fontenay-aux-Roses and Montrouge. We have different missions. So the first missions are the control of civil nuclear activities. Second missions are the research. We have missions of expertise, and we have missions of training and public information. I belong to the research area, and this research pool is divided into three departments, so the environment, health, and nuclear safety. And each department have different lab. So I belong to the lipid department, and the goal is to develop the knowledge on the health effect of the ionizing radiation on humans in the context of low dose exposure particularly, but also all the exposure throughout epidemiological studies. So we have different kind of exposure. We have the workers, the patients, and the general populations. And we have different studies for each kind of exposure. So here are the national studies that we have. For the workers, we have studies in the nuclear industry, in the medical staff, and the flight attendants. In the patients, we have study on diagnostic exposure, but also in therapy exposure. And finally, we have studies in the general population exposed to ionizing radiation. We are included in several international projects. So I just mentioned the BICOM and the INWORKS project, but we have also the PUMA and IPO project. For the patients, we have the EPCT, Medirad, and Harmonic. And for the general population, we have the Radionorm study. And finally, we have a big project who combine all the kind of exposure. So we have exposure from worker, patients, and general population, and we would like to assess the radiological component of the human exposome. And today, so I'm going to focus my talk on the side effect of radioiodine treatment in thyroid cancer patients, so in the START cohort. So the START study has been set up in order to focus on the salivary dysfunctions after radioiodine treatment. But after, during the setting up, we thought that it was good to add some aspect like quality of life and genetic biomarkers. So we have a strong collaboration with the Hôpital Pitié-Salpêtrière and the University of Barcelona. So at the beginning, I was invited to speak only about the paper of dysfunctions of the salivary and lacrimal glands, but I also had some results on the quality of life of patients treated by radioiodine because it's the same cohort and we have different results. So I think it's interesting also. I have some words of context to introduce my talk. So I guess you know that the number of cases of thyroid cancer increase every year and everywhere in the world. And the therapy for differentiated thyroid cancer is usually a thyroidectomy, so surgery, associated to a complementary radioiodine capsule. And it's here the focus of my talk, because you know that the radioiodine capsule comes to destroy the last cells of cancer, but it can be captured by the salivary glands. And after that, we can see possible inflammation or changes in the saliva production or impacts on the quality of life and the nutrition of patients. But we have inaccurate incidence of salivary disorders in the literature. We don't have any dose-response relationship in order to see if the more we have an activity and the more we have disorders or not. We don't have any calculation of the dose received by the salivary glands precisely, which can be different to the administered activity. Because, you know, when you take a radionuclide, a part is excreted and a part is stored in the body, but we don't know exactly which part is stored in the salivary glands. We don't have any identified clinical or genetic factors to define the patients at risk of salivary dysfunctions. And finally, we have only few studies on the quality of life of patients treated by radioiodine. And most of the studies on quality of life have not focused specially on the radioiodine part, but they take into account all the therapy or the treatment. So the objective of the STAR study are to estimate the incidence of salivary dysfunctions, to characterize the patients at risk of dysfunctions, to validate dosimetric methods to calculate the dose at the salivary gland, to estimate dose-response relationship between the exposure and the dysfunctions, and finally to assess the quality of life in patients treated by radioiodine. And in the long term, it's to allow the delivered activity to be adapted to the expected risk of salivary dysfunctions. So in terms of methods, we have included 139 patients. All were candidates for radioiodine therapy for differentiated thyroid cancer. It was at Pitié-Salpêtrière hospitals, and we had two groups of treated patients, one treated by 1.1 gigabecquerel and the second one by 3.7 gigabecquerel. And we included a patient for control group, so they had the surgery, but they didn't have the radioiodine therapy. In terms of process, so the patient had the thyroidectomy, and some weeks after they had the radioiodine therapy. So we were with the patients at inclusion, so they came for the treatment, and they were in the waiting room, and we offered the possibility to participate to the study to the patient, and if they agree, we collected clinical information, salivary samples, and we asked for 5 questionnaires. And 6 months after, the patients came again to the hospitals in order to have an exam for the cancer follow-up. And we were at the hospital to have a new follow-up for our study. So we had new salivary samples, and we asked again for the questionnaire. And 18 and 36 months later, they don't come anymore at the hospital. So we had phone calls, and we asked the patient again about the questionnaire. And of course, for the patient in the control group, they don't have the radioiodine treatment, but they were included at the same time, and they had the same follow-up after. And for the topic today, the focus of my talk, I will focus on the T0 and T6 follow-up. In terms of dosimetry, so we fix on the patient 3 dosimeters under the earlobes and at the sternal fork. So we put at the inclusions, and the patient had this dosimeter during 5 days. And after, we removed the dosimeters, and we had a team in our institution who worked specifically on the dosimetric reconstruction. And they had a calculation of the dose precisely received by the salivary glands based on the dose recorded in the dosimeters, because the patients emit some radioactivity. Here I present the different outcomes of the different variables that I analyzed in this study. So we have variables on the salivary dysfunctions. We have also on the lacrimal dysfunctions, And after we had the work on the composite criterion, which combined different variables that I'm going to present. So we have different way to analyze. We have continuous outcome and we have binary outcomes. And in terms of continuous outcome, we have unstimulated saliva flow and stimulated saliva flow. So the difference is because we ask the patient to split into tubes during 1 minute. And after we asked the patient to, they had a chewing gum to activate salivary glands, and they split again into new tubes during 1 minute. And the saliva before chewing gum, it's unstimulated, and the saliva after chewing gum, it's stimulated saliva flow. And after, from these samples, we had a biochemical analysis, and we got salivary biochemical concentration in sodium, potassium, chloride, calcium, and amylase. For lacrimal dysfunctions, we had a questionnaire, so validated questionnaire, and we got a score between 0 and 100. And here, the scales, you can see a score between 0 and 12, it's quite normal, but above 12, we can consider that the patient had eye dryness. For the binary outcome, so we used the continuous outcome to create these variables. So for example, for unstimulated hyposalivation, we coded as yes when the saliva flow was under 0.25 milliliters per minute. For stimulated hyposalivation, it was the same, but the threshold was 1 milliliters per minute. And after we had questions like, do you feel that your mouth has been or is dry? And it was coded yes, if the patient said yes. And we also asked, did you experience pain in the parotid gland? And yeah, again, we have a response yes or no. For lacrimal dysfunction, we had the same process. We coded yes when the score was above 12. And finally, so we had variables that we call gland disorders, and it's a combination of the different previous variables. And yes, if the patient said at least one yes, it was coded yes. Now it's for quality of life. So we used the medical outcome study short form 36, so SF Francis 36, and we can divide it into 8 subscore, and after we can calculate 2 scores, so it was the same in continuous outcomes. After we had the hospital anxiety and depression scale to measure anxiety and depression. So we had a sum of 14 items rated from 0 to 3. This score can be divided into anxiety and depression state. And we can create binary outcome from this scale into anxiety symptoms and depression symptoms. And finally, we had a visual analog scale to measure the nutrition of patients. So we have the question, did you reduce your dietary intake since your surgery or since the last follow-up? And if the patient said, I eat anything anymore, I don't eat anything anymore, sorry, they will code it 0. And if they said, yes, I eat as I always do, they had 10 in the score. And here, just to see the direction of the score, for the SF36, for example, the higher the score, the better is the health state. But for the HAD, it was a reverse, that the higher is the score and the worse is the psychological state. And for the visual analog scale, the higher the score, the better is the nutrition state. In terms of statistical methods, so we had the same methods for lacrimal and lacrimal dysfunctions and the quality of life. So we had descriptions, so we used means or t-test, paired t-test, McNemar test, etc. And after we compute statistical models, so we used logistic regression for the binary outcomes, and we used linear regression for the continuous outcomes. For all the models, we used a random effect on the patient to account for the correlation between repeated measurements of each patient at different covariance structures. And finally, we have models which compare T6 and T0. It's really in comparison between pre and post therapy. So the regressions allowed to assess the factors statistically associated with the changes in the outcomes between pre and post therapy. And for these models, we had covariables of adjustment. So for example, in the lacrimal and salivary dysfunctions, we had the age at the time of interview, we had the use of painkillers, we had the score in anxiety and depression, we had the history of systemic disease and menopause status. And for the quality of life, we had quite the same. It was age at time of interview, medication consumption, salivary and lacrimal dysfunction, and menopause status. And the covariables were identified from literature, but they were tested in the univariate analysis. And if they were significantly associated to the outcomes, we included them in the multivariate analysis. So here are some characteristics of the study populations. So it's just descriptive. We had more women than men, but it's usual in this kind of study because the thyroid cancer concerns more women than men. The mean age was 47 years old. We had more papillary cancer, but we had also some follicular cancer. In terms of TNM stage, we had low grade of cancer mainly. We have mostly patients who had recombinant TSH elevation protocol. Most of the patients had no history of thyroid cancer, no salivary disorder history, and 20% of the patients had hypertension. For the exposure, so it's a reminder. We picked on the patient 3 dosimeters. Even from these dosimeters, we had a calculation of the dose received by the salivary glands, and we have glands on the right and on the left. So we have a dose for left and right glands, and we can see that it's quite the same dose inside within each group of activity dosimetry for the right and the left. So we had the mean dose between left and right side. And after we had a calculation of the mean dose per gigabecquerel administered. And we can see that the dose here, it's quite like an absorption rate, or the dose is the same for each group of activity. For the following of my talk, I will just keep the administered activity and the mean dose on exposure variables, because we have already a lot of variables, so I focused on these variables. Here I compare the patients, so the outcomes before and after therapy. And we can see, so in bold are the significant value. And we can see here that only the stimulated saliva flow is significantly lower at 6 months follow-up compared to inclusions. And we don't have any significant difference for the other outcomes. For the dry mouth sensation, it was the questions, and we can see significance here. It means that we have more patients who complain about dry mouth sensation at 6 months follow-up compared to before therapy. For the question related to pain in the parotid glands, we have no difference between before and after therapy. And when we compare the concentration, so the biochemical concentration in the saliva, we have a significant difference for almost all the concentration, except for the sodium. And for the other, we can see that the concentration increased after therapy. For lacrimal outcome, we can see that we have significance for the two way to approach the lacrimal outcome. And we can see that we have a higher score of eye dryness 6 months after follow-up. And we have more patients with eye dryness at 6 months. And finally, here is the composite criterion, so it takes into account all the variables that I present until now, and we have no difference between before and after follow-up. In terms of incidence, we can see that the incidence vary from 3.7 to 20%, depending on the outcomes that we consider. But we can see that 45% of the populations had at least one disorder at 6 months follow-up. Here we compared, so we are only at 6 months follow-up, and we compared the incidence in the two groups of treatments. So in the low group, I would say, and the high administered group. And we can see that we don't have any difference between the two groups in terms of incidence, but it can be related to a lack of statistical power, because when we look at precisely in the group, we can see that the incidence is higher in the high group of activity. Now we are going to move into the models, so the statistical models. I don't know if you are familiar with that, but I put in bold the significant values, and we can see that for the dry mouth, the results are significant. So we can see that the dry mouth is significantly associated to mean dose or administered activity. We have a significance also for dry eyes, only in the group of 1.1 gigabecquerel of therapy. So the risk increased in this group. Significant relationship between dry mouth and dry eye sensation with the dose received by salivary glands or with the activity level are shown. Now, if we look at the objective outcomes, so it's in continuous variables. We have the stimulated flow, we have the concentration and the OSDI score. We can see that we have significance in the stimulated saliva flow, meaning that the saliva flow, stimulated saliva flow decrease with the dose. And here for potassium, for example, we have an increase in concentration of potassium with the dose. So we have negative dose-response relationship between stimulated saliva flow and the dose received by the salivary glands. Now we move to the quality of life. So here I present the 8 subscore of the SF36 questionnaire. Again, in bold, we have only one item which is significant. So it's the raw physical subscore. meaning that we have a positive and significant dose relationship between the raw physical subscore and the dose received by the salivary glands or the administered activity. And if we look at the quality of life in overall, we have the two score of the SF-36. So we have the physical component score, the mental component score, and here we have the visual analog scale on the nutrition, and here we have the HAD score, so on anxiety and depression. And in bold, we have only significant for the physical component score. And if we look at the binary outcome for anxiety and depression symptoms, we have no significant relationship. So here we can conclude with the positive and significant dose-response relationship between physical and component score and the dose received by the salivary glands. So here I present just one slide on the genetic analysis that have been carried out on the START study. So I present a presentation that I had before. I'm not an expert, so yes, it's the University of Barcelona who works on that. So they considered 88 patients. 36 had salivary gland dysfunction, so it was coded as dysfunction by us. So they use our codage to do the analysis. So yeah, they compare patients with salivary dysfunctions with patients without dysfunctions. And they had DNA extraction and they focused on the whole exome sequence. And after they had bioinformatic analysis. And they found 4 high impacts SNP. So SNP is single nucleotide polymorphism, it's variants. And it's like biomarker who characterize the patients with gland dysfunctions. And they had a look on the literature and they found that this gen, so the TOR, I don't know how they call that, but is highly expressed in the thyroid tissue and a strong susceptibility in gene candidate for xerostomia. And the PRH1 codes for a proline-rich salivary glycoprotein, which is secreted by parotid and submandibular glands. So the 2 genes are candidate for xerostomia. It's people are susceptible to xerostomia when they had these genes. So yeah, the conclusion of this study is some identified genes are expressed in thyroid cells and or in salivary glands, and 2 have been described as candidates for xerostomia. So I'm going to conclude and to make a sum up of my talk. So for the salivary and lacrimal dysfunctions, we got incidence 4 to 20% of the patients, depending on the outcome, had salivary dysfunctions. And 45% of the patients present at least one disorder at 6 months follow-up compared to before therapy. We had no difference statistically in incidence between the 2 groups of activity between 1.1 gigabecquerel and 3.7 gigabecquerel. We identified several risk factors of salivary lacrimal dysfunctions like age, painkillers non-use, anxiety and depression, history of systemic disease, and menopause status. And our results are toward a decrease in the gland activity after radioiodine because we had significant dose response relationship for dry mouth sensation, stimulated flow, salivary concentration in potassium, and dry eyes. But these results do not show any obvious clinical disorder after radioiodine therapy. It's, I would say, like small disturbance of the flow in saliva, but it's not really grave, I would say. For the quality of life, we don't have any impaired quality of life in the 2 treated group at 6 months, but the results are toward a reduction in the pain and the functional impairment at 6 months follow-up. But be careful, because we can't say that the therapy reduces the pain. Just I have a small explanation about that. As a record, reminder, here is the process. So we had a T0 and T6, and we focused our analysis on this part of the patient's timeline. And in the literature, we have seen that the quality of life decreased after surgery and increased after iodine, for example, to have quite the same level than before surgery. And as we are focused our analysis on the T0, T6, we are here, and that's why we had an increase in quality of life, but it's not related to the radioiodine therapy, I would say. In terms of strengths, our study has a good study design because it compares the same patient before and after the radioiodine therapy. We used objective and subjective outcomes. We had an estimation of the dose at the salivary glands, which is very new in this kind of analysis. And we had adjusted dose response calculations thanks to the different risk factors that we had collected during the study. In terms of limit, we had a small study population, 139. It's not really huge in epidemiology. We don't have any standardized indicator for the hyposalivations. We have nothing which is internationally validated in the literature, so we use different outcomes. But yeah, we need something more validated in the science and research. We need a comparison with controls because I presented here only analysis in treated patients, but we have also controls. And we don't have any data on the quality of life before diagnostic to see if the level of quality of life after is the same before treatment. In terms of perspective, so we would like to assess the salivary and lacrimal dysfunctions in the next follow-up, so at 18 and 36 months of follow-up. And we would like to assess the evolution since the inclusion, so since T0, and the same for quality of life. So here it's ongoing analysis. It will be carried out by our PhD student. We would like to compare the response of the treated patients with the control group on the basis of questionnaires. So at T6 and T18. We would like to develop international collaboration to extend this study in order to have more patients to analyze and to confirm our results with other patients. In terms of genetic analysis, we would like to continue the work, and now to see are some patients more sensitive to therapy than others, because for the until now they work on the susceptibility of patients to have xerostomia, but here it's another aspect. It's to see if patients can be sensitive to radioiodine or not. And again, the genetic analysis should be extended to a larger number of patients, and why not in a European multicenter study? It's in mind. And we would like to assess other potential side effects like fertility or secondary primary cancer in these patients. Yes, thank you very much for your attention, and thanks to all the team at the Pitié-Salpêtrière Hospital, which is very nice with us, and yeah, which allows to have the study very nice. Thank you very much.
Well, it's a pleasure to be here. Thank you very much, Dr. Erkin, for the kind invitation and a very kind introduction. It's really an honor to speak to the participants, and it's a pleasure to follow Dr. Baudin and want to congratulate her on an outstanding investigation. It's studies like this of epidemiology that really build on the foundation of our understanding of this unfortunate consequence of therapy with radioiodine. And I think from her study, we know more about the incidence, particularly in her group of patients, the dose relationship of the problem, and very interestingly, the potential genetic susceptibility of some patients for this. As Dr. Erkin said, I have a primary interest in salivary gland disorders, and in 2004, we began a minimally invasive salivary gland program here in the United States, which included silendoscopy. And I'll talk to you about our experience in managing some of these patients with this modality. Here, greetings from Baltimore, Maryland. This is our campus, and we have a very short history, but an important history in medicine, and many seminal contributions to thyroid surgery were done here by William Halsted and some of his disciples. I have nothing to disclose. As everyone knows, radioiodine is a key treatment modality for both benign and malignant thyroid diseases. So it's also used in hyperthyroidism, and we rarely see any patients with this consequence of therapy in those patients. But for the malignant thyroid patients, this is where we see the problem. And of course, the utility of this therapy is the propensity of thyroid follicular cells to uptake the radioiodine, and then the beta emissions from the radioiodine cause cellular necrosis, and this is important therapeutically. The salivary glands also take up the radioiodine. There is a selective sodium iodine symporter in salivary glands that really is most prevalent in the ductal epithelial cells. It doesn't really damage the acinar cells, but it damages the ductal cells, and this results in ductal injury to the salivary glands, a very pervasive plumbing problem, so to speak. And this tends to be dose related, and it's very important to understand that the major salivary glands are a little different. There are serous glands like the parotid gland. These are more susceptible than the submandibular and the minor salivary glands in terms of this consequence of therapy. Another thing I'd like to emphasize is when people get this, a lot of people are really not informed of this potential consequence of therapy. When we ask people, gee, did you know that this could happen? They frequently say, no, this was never discussed. So I think it's an important for individuals that are receiving this therapy that they be advised of this potential consequence of treatment. How does it damage the glands? It can cause both an acute and chronic inflammation in the glands and a ductal narrowing and stricture formation. And this results in a diminished and altered saliva, as was mentioned by Dr. Baudin in her study. Some of the concentrations are altered in the saliva. The salivary stagnation results in some obstructive symptoms. This is typically pain and glandular swelling that can be exacerbated by eating and drinking. And then patients also can have dry mouth and a taste alteration related to this. The clinical incidence and severity is quite variable, as described in the literature. And based on a review of the literature, really the cumulative dose really appears to be the only risk. So that's why Dr. Baudin's investigation, I think, helps us understand this a little bit more. So if you look at a number of studies here, here's one reported that you can see there's quite a variable incidence of sialadenitis, which ranges from up to maybe 2/3 of patients to as low as less than 5% of patients. So it's quite variable, and seems to be fairly idiosyncratic in some patients. In other words, some patients can receive a fairly good dose and have no alteration in their saliva or salivary glands, and some can be very severely affected. Here's an example of a patient we saw. You can see the swelling on the right-hand side of her face that is fairly typical of the swelling. You can see also the stigmata of the neck incision. She's had a total thyroidectomy and a neck dissection there, and received radioiodine. Morbidity and quality of life can be effective. There's a very good study written here describing 145 patients that received radioiodine, and there was a dose-dependent increase in sialadenitis, with those receiving over 150 millicuries having 2.5 times more higher likelihood of having sialadenitis. And then if they received greater than 150 millicuries, there was a reduced oral and overall quality of life in this particular study. There are a number of things have been done to try to preemptively avoid this problem in patients, and I list them here. Unfortunately, none of these have really been effective. So they've tried stimulating the saliva before, during and before treatment, or slowing the saliva, adding anti-inflammatory medications. A number of different compounds have been tried that have been, deemed to be radioprotective. They've tried, like I said, to stimulate the saliva flow, and even vitamin therapy. And interestingly, a study from Japan that even included aromatherapy as a potential preventative measure here. Unfortunately, none of these have really shown any preventative benefit. When patients have this problem, we typically treat them, medically to begin with. That is, we tell them to stay very hydrated, to massage their glands frequently, to stimulate the saliva with sialagogues, sour candy, gum, lemon drops, things like that. Apply warm heat to stimulate blood flow, anti-inflammatory medications such as Motrin and things like that. And then we can use cholinergic medications like Salogen and others to try to stimulate saliva. And this can benefit some patients, but some patients that are recalcitrant to this type of management and still have problems, then they're considered to be candidates for more interventional measures, which include sialendoscopy, and I'll describe that. Rarely do we ever consider sialadenectomy, although that has been reported and has been done in patients with real severe problems. But now with the advent of sialendoscopy and the benefit thereof, rarely would that be considered now. Sialendoscopes are very interesting instruments. This is an example of a sialendoscope. They're miniature telescopes, and the size can go down to 0.8 millimeters, so very small. If you think of the ductal diameter in the parotid gland, which is most commonly affected here, the ductal diameter is only about 1 to 2 millimeters in the normal patient. And so this allows us to visualize the interior ductal system of a gland, and it's really quite interesting technology. What we do for this is basically we introduce the scope in a patient affected by radioiodine sialadenitis after we dilate the ductal opening, and then we look in the ductal lumen and inspect it. We advance the scope under direct vision, and we're doing this simultaneously. We're flushing with very copious amounts of saline solution, and we want to basically get an engorgement of the gland doing this. These are the dilators that we use. They're small little probes that we atraumatically place into the duct, and this can be an adjunct to the use of the scope. By simply putting the scope in, you're in effect dilating the duct. And so here's an example of the parotid duct being cannulated and dilated by one of these. We typically, as you can see, the endotracheal tube there, we do this under general anesthesia as an outpatient. Some centers offer this as in the clinic, but I think to really be very effective, we find it's much better and better tolerated to do it in the operating room. And so this is an example of, we've placed the scope, and you can see up on the screen there what we visualize. That's kind of a normal appearing duct. You can see the lumen and the kind of the very pink normal anatomy of the ductal system. In patients with radioiodine sialadenitis, however, they have altered visual inspection. And you can see here that in these patients, some examples here, there's ductal debris, mucus plugs, and then there tends to be a very pale mucosa of the ductal system, very altered compared to the normal appearance of ducts. After we do the procedure, this is what we want to see. We want to see the gland fully engorged. And what we're in effect are doing is doing a hydraulic expansion of the ductal system with the saline installation. We reported our results at UCSF when we began doing this. We reported these, and we had very good success. You can see a partial improvement of patients of 36%, 55% had complete resolution of symptoms, and only a small proportion of patients had no improvement whatsoever. Since then, there's been a number of other centers that have reported their results. Here's a nice systematic review of the literature that was done, 8 studies, 122 cumulative patients, and looking at the results of all these combined studies, there was about a 75 to 100% overall clinical improvement of obstructive symptoms. Xerostomia is a different issue, and there have been mixed reports, and some studies have shown no improvement in xerostomia following this procedure, and there are some that show some improvement. Here's one from MD Anderson, 26 patients, where they had some resolution of their xerostomia symptoms in a good portion of their patients. I think to some degree this may depend a little bit on when silendoscopy is done. We know that patients that have chronic obstruction of the salivary glands, they tend to have more problems with salivary output dysfunction. Here's another study looking at xerostomia where they looked at 15 glands, and they did an objective assessment of salivary function before and after silendoscopy, and there was really no statistically different flow rates before and after silendoscopy in this study. The proposed mechanism of benefit of this is, as I said, the instrumental dilation of the duct and the papilla, and then a hydraulic dilation of the ducts with the saline and flushing debris and ill humors from the ducts. Some individuals are proponents of steroid installation after the completion of the dilation, but really its benefit is unclear relative to just the saline irrigation. So in summary, silendoscopy is an option for patients that are recalcitrant to conservative medical therapy if they suffer from iodine-induced sialadenitis. It's effective in providing a sustained period of patient-reported improvement in symptoms and improved quality of life. And we need further experience with this modality and other modalities with more long-term outcome data to make further advancements in this area. So again, thank you very much for the opportunity to participate in this, and happy to participate in some questions and answers.
David, thank you very much. And Dr. Baudin, thank you for a wonderful presentation. David, do you have any idea kind of what the exposure to radioiodine is in the population that make it to see you? Yeah.
Yeah, it tends to be those patients that have a higher dose of radioiodine. Like, as I mentioned, we never see patients that have been treated for hyperthyroidism, for instance, with radioiodine. It's only those that have received good doses of therapeutic. But as I mentioned before, it's a little idiosyncratic. So there are some patients that can have pretty severe symptoms with a fairly small dose of radioiodine, and some that have it with a higher dose. Again, Dr. Baudin's work sheds a little bit more light on the dose relationship in terms of the incidence here.
Dr. Baudin, I congratulate you on your study. It was very, very detailed and very comprehensive. Were you surprised that you didn't find a difference between the lower and higher dose in terms of the amount of damage that was caused?
Yeah, thank you for the invitation again. Yeah, we don't find any difference between the highest and lowest group, but as I mentioned, it may be related to a lack of statistical power, because we had, I would say, around 50 patients in each group, and we need more patients to have a significance, I think, because when we look at the incidence by group, we have a higher incidence in the highest group of activity. So yeah, we can't say that we don't have difference. We say that the results are not enough powerful, I would say.
Okay, and just a quick, maybe if you can give us a sneak peek at the a longer term follow-up that you've done. Is there a greater incidence of salivary dysfunction that patients are reporting at 36 months than they did at the earlier analysis at 6 months?
We don't know yet. We don't have any results for the moment. Yeah,
I understand.
It will be the focus, yeah, on future analysis, and yeah, we will see.
Great, terrific. Dr. Shaha, I know that no one gets radioiodine if they walk into the doors of Memorial Sloan Kettering, so I'm sure this is not really a relevant discussion. But maybe you can think back to an earlier time when you did administer or recommend administering radioiodine. Do you have any perspectives on salivary and lacrimal dysfunction here?
Well, first of all, I'd like to congratulate Dr. Baudin and David. David did a fantastic job, and Baudin, your work is seminal. I also would like to congratulate David for his chairmanship for a long time at Johns Hopkins and bringing up the standards so high. So congratulations.
Yeah,
Coming back to radioactive iodine, we do use radioactive iodine, but we are very selective in a high-risk group. And we do see sialadenitis. What happens is, from a clinical standpoint, they come, they complain, you spend some time, you sit with them for half an hour, they go home, they call once or twice, and then they say, I'm going to live with this. Those patients who are very anxious and get very concerned about it, we send them to the salivary gland expert. They talk to them, but the true incidence of endoscopy and intervention is very small. The problem is we don't have a denominator group to identify to see how many people are really suffering from this. We really lack the denominator, because all that we do is like David's presentation and Dr. Baudin's presentation, the patients who came to their shop with specific complaints. Now, those when they get better, I'm sure you have done a fantastic job. And it is not uncommon we send the patient to New York Hospital or to another institution for endoscopy. They come back and they're quite happy. And I think this is a technology which is in its infancy for radioactive iodine, but it has a promise, absolutely no doubt about that. Whether it will really help and is the expertise there around the country, that remains to be seen.
David, let me give you a final question here. Are there any objective measures of what the impact of high hydrodilation of the gland and the ductal systems, and in terms of change in flow.
Yeah, it does not appear to have changed in that one study that I referenced, it does not appear to change the flow. So, it's interesting that there have been some reports of improved or resolution of xerostomia, which really the symptom that would be, I think a good indicator of improved salivary flow. But again, I think it's quite variable.
Great. All right, well, we unfortunately are up against the 9 o'clock hour on the East Coast. So I want to again thank Dr. Eisele, Dr. Baudin for a really interesting discussion. Dr. Baudin, we appreciate your joining us from overseas and look forward to the rest of your analysis on this study group as the data becomes more mature. So thanks everybody for joining us and look forward to seeing you next week here. Thanks, David.
Thank you.